Good evening, everyone. It is 7 o'clock. So we start the second part of our 9th Masterclass on abdominal tuberculosis. For those who were not there yesterday and who are watching this video today for the first time, these Masterclasses are part of Jaipur Surgical Tutorial, which is an online academic activity which we have been conducting at the Mahatma Gandhi Medical College and Hospital for last 3 years. And this is being coordinated by my colleague, Dr. Anand Nagar, who is an associate professor of HPB surgery and liver transplant at my institution. In the Jaipur Surgical Tutorial, we conduct a session every Saturday, 9 to 10 a.m. Indian time, which is online. And in addition, recently we have started a Jaipur Surgical School, which is on Friday afternoon, 3 to 4 p.m., which is mainly for our colleagues and students in Africa who could not join the morning sessions. So the Jaipur Surgical School is being looked after by Dr. Piyush Vashne, who's at the AIMS Jodhpur, and Dr. Kailash Kodia, who's at AIMS New Delhi. And these master classes we do last Thursday and Friday of every month, 7 to 9 p.m. We cover one topic in 2 parts of 2 hours each. We've already conducted 8. And this is the 9th Masterclass which we are doing now. In between the sessions, I will project information about as to how new students and new colleagues can join these educational activities. You just have to send a WhatsApp message and then you will get all the information about these activities. So to moderate this session, I have my colleague, Dr. TD Yadav, who is a professor of GI surgery at Institute of Medical Education and Research in Chandigarh. So over to you, TD. Maybe I'll introduce the first speaker because you may not know. Dr. Chetna Mehrol is my colleague in the Department of Pathology at the Mahatma Gandhi Medical College and Hospital. And she is going to talk to us about the histological diagnosis, the point which we were discussing yesterday. And Dr. Sitaram and other speakers also emphasized that although radiology and endoscopy is highly suggestive, but to treat with anti-tubercular treatment, we need a histological diagnosis, and also because it is a great mimic, as we saw yesterday, to make sure that we are not missing malignancy. Again, we need a histological diagnosis. So Dr. Chetna is going to tell us about the histology of tuberculosis. Chetna, please.
Good evening, everyone. Thank you, sir, for the kind introduction.
So we also welcome Dr. Sitaram, who was the former chief of HPB surgery at CMC Vellore, and my colleague, Dr. Sanjay Gambhir, who is the chief of nuclear medicine at SCPGI in Lucknow.
Good evening, everyone. So thank you, sir, for the kind introduction. So I will be talking about histopathological diagnosis of abdominal tuberculosis, mainly focusing on the diagnostic features. Also, I will be talking about histopathological diagnosis of Crohn's disease. Again, the key diagnostic features and the differentiating features between the two, as the Crohn's disease is one of the closest differential of tuberculosis. So few words about abdominal tuberculosis from pathology point of view. It's an infectious disease of colon or small intestine caused by acid-fast bacilli, Mycobacterium tuberculosis. Although the GI tuberculosis constitutes 10% of extrapulmonary tuberculosis cases. Most commonly, as we have studied also, the ileocecal region is the most common site, followed by jejunum and colorectum. However, the isolated colorectal involvement is uncommon. The rectum and anus are rarely involved, as the anus represents only the 1% of abdominal tuberculosis. So the most common site for now is ileocecal region. So talking about pathophysiology, most common route of infection is by ingestion of infected unpasteurized milk or by ingestion of the infected sputum. Secondarily, it can be spread by the hematogenous route by any tubercular foci elsewhere in the body, sir. Why ileocecum? The point is because the ileocecum is the site having abundant lymphoid tissue. So the type of hypersensitivity reaction which is responsible for the pathogenesis here is cell-mediated delayed type hypersensitivity. reaction. So in short, what happens?
Dr. Chetna,
I will be covering about the histopathological diagnosis of abdominal tuberculosis, mainly focusing on diagnostic features. Also, I will be talking about histopathological features of Crohn's disease, which is one of the closest differential after tuberculosis, and the differentiating features between the two on histopathological grounds. So, a few words from abdominal tuberculosis from pathological point of view. It's the infectious disease of colon or small intestine, as we all know, caused by acid-fast bacilli, Mycobacterium tuberculosis. And the GI-TB constitutes about 10% of all extrapulmonary cases. So ileocecal is the most common site, followed by jejunum and colorectum. However, the isolated colorectal involvement is uncommon, sir. Rectum and anus are rarely involved, as anus represents only 1% of abdominal tuberculosis cases. So talking about abdominal tuberculosis from pathological point of view, it's the infectious disease of the colon or the small intestine by acid-fast bacilli, Mycobacterium tuberculosis. The GI-TB constitutes 10% of all cases of extrapulmonary TB. The most common specimen, the resection we got are ileocecal regions only, followed by jejunum and then the colorectum. However, the isolated colorectal involvement is uncommon, whereas the rectum and anus are rarely involved, as anus represents only 1% of extrapulmonary cases, sir. Next. So the most commonly, the abdominal tuberculosis is caused by ingestion of infected unpasteurized milk or by infected sputum. The second most common pathway is via the hematogenous route from the tubercular foci elsewhere in the body. So why ileocecum is the most common organ involved by the abdominal tuberculosis? It's because of the abundance of lymphoid tissue. So the cell-mediated delayed type 4 hypersensitivity reaction is responsible for the pathogenesis. So in brief, the bacilli are first phagocytosed by the macrophages. These macrophages release some factors. The most important ones are the interferon gamma. These interferon gamma, this causes the blockage of phagolysosome, because of which there is continuous replication of these bacilli, leading to bacteremia and ultimately resulting in primary tuberculosis, sir. So in pathology department, when we talk about histopathological examination, then we receive two types of specimens in relation to abdominal tuberculosis. First, we get small biopsies, which are the endoscopic mucosal biopsies, and the second, we have the resection specimens. So talking about endoscopic biopsies first, the tissues we receive in our department usually varies from 0.1 centimeter to 1 centimeter in greatest dimension. We usually completely processed it, whole summated it, and we have to look for two features in small biopsies. Here I'm making a very important point. The two features which we look in small biopsies are, first is the crypt morphology. Second is the presence or absence of epithelioid cell granuloma. So here comes two scenarios. The first scenario says if the crypt morphology is normal and there is presence of epithelioid cell granuloma, then it is hinting towards tubercular pathology. That is scenario number one. Whereas the second scenario says if the crypt morphologies are altered, that means if the crypts are distorted and if you can see the signs of activity, that means crypt abscess are there, cryptitis is there, along with it you are seeing granuloma, then in that case also it will not rule out the possibility of tuberculosis. Rather, in that case we give it as chronic granulomatous inflammatory pathology, keeping the Crohn's as secondary differential. Now, in that case, we usually talk to our clinical friend and we ask for repeat biopsy and also look for the endoscopic findings and clinico-radiological correlations, sir. And one more important thing which I would like to mention here is usually the caseous necrosis, which is a diagnostic hallmark for tuberculosis, is usually not appreciated on small endoscopic biopsies. So in that case, we usually give it as, if the granuloma is there, chronic granulomatous inflammatory pathology, and in that case, the final diagnosis is usually made on the resection specimens. So grossly, the abdominal tuberculosis are of three types. The most common is the ulcerative type, which comprises of 60% of the cases, followed by ulcero-hypertrophic type, which is 30%, and the last is hypertrophic, which accounts for 10% of the cases. Sir. Usually, the tuberculosis has transverse ulcers. That means the tubercular ulcers are multiple. They are usually superficial. And what do we mean by transverse? They are usually perpendicular to the long axis of the bowel. Then you can see mucosal folds, which are thickened fibrotic walls, the stricture formation, and the inflammatory nodules within the mucosa. So these are the gross photos of intestinal tuberculosis. First, I have told the most common one are the ulcerative type. As you can see marked by the arrow, we can see this ulcerative mucosa. This is the cut open specimen of a bowel from the mucosal aspect. You can see marked by the arrow, there is this presence of ulceration, whereas on the adjacent, the mucosa is completely normal. Although it is little edematous. On the second hand, you can see hyperplastic type, you can see there is hypertrophy. You can see the inflammatory nodules, which is the second most variety of presentation of abdominal tuberculosis. Now again, this is the ileocecal resection specimen, the cut open specimen of ileocecal resection. As you can see, there is presence of appendix and there is adhesion of ileum along with cecum. So you can see there is a thickened fibrotic wall which is marked by the arrow. Next, on the serosal aspect, you can see these multiple gray-white nodules and tubercles, which are diagnostic hallmarks of tuberculosis on the serosal aspect. And in the second image, you can see on the mesenteric side, there is involvement of the lymph nodes. And the cut surface shows presence of this gray-white foci, the caseous cheese-like material, which you can appreciate in the lymph nodes marked by the arrow. Okay, now talking about microscopy, taking sections from that, in figure 1, you can appreciate the most common organ I've talked about it, ileocecum. So we have to identify whether the section is adequate or not. So check for the adequacy. We can see there are presence of these lymphoid follicles, which are nothing but the PS patches, which indicates that this section is from the ileum. Okay, now on the right hand side in figure 1, you can see these are the benign mucosal glands, and within the lamina propria, you can see the granuloma formation, which is the caseating epithelioid cell granuloma along with Langerhans giant cells. I have marked it with arrow. So there are three things which you can appreciate in figure number 1. First thing, there are presence of this lymphoid follicles on the left hand side, which is just the collection of lymphoid aggregate, indicating it that this section is from ileum because these are PS patches. On the right hand side, you can see the benign mucosal glands, which are just crypts, and there are presence of these granulomas marked by the arrows. In figure number 2, again, it is the hyper view from another focus. You can see a clearly visible granuloma present within the mucosa and submucosa marked by the arrow. Now, these are the HE pictures from the mesenteric lymph nodes. You can see from the mesenteric lymph nodes, now you can just imagine these are the pinkish amorphous granular material is just caseous necrosis marked by the arrows. So the upper figure number 3 shows extensive areas of caseous necrosis and granuloma. The lower figure is just the hyper view of the same, indicating again the granuloma and pinkish amorphous eosinophilic caseous necrosis. And if you can appreciate, there are presence of these Langerhans giant cells. The Langerhans giant cells are characteristically horseshoe shape. By horseshoe shape, I mean the nuclei are present at one pole, whereas the other pole is empty. Yeah, marked by the arrow. And the caseous necrosis is this pinkish material, which is amorphous because it has got no shape. Second, it is granular. When we look at the slide, it is a little granular, and this is eosinophilic. And presence of these Langerhans giant cells, which is the diagnostic features of tuberculosis. Next slide, please. Now, these are the figure number 5. These are the Zedden stain to confirm the presence of AFB, although I would like to mention a very important thing here, GI tuberculosis is a paucibacillary disease and AFB might not be identified from variety of clinical specimens. So absence of AFB does not rule out tuberculosis. So in that case, we have to go with the morphology and we have to correlate clinico-radiologically, sir. So in ZN stain, you can see the bright red rod forms. These are the bacilli which are looking bright red and they are present in a background of necrosis, which is all bluish. Now again, the second picture is showing, marked by the arrow, clusters of these bright red rod forms. This is from the mesenteric fat. That is why it is a little acellular. And the upper image is from the necrotic background, highlighting the bacilli. So I have talked about that if the crypt morphology is normal, but you are seeing granulomas, then in that case, the first differential that comes into our mind is Crohn's disease, because Crohn's also involves the terminal ileum and cecum region, but to call it Crohn's on small biopsies is a little tricky. So we give it as chronic granulomatous inflammatory pathology, and for that you have to correlate clinico-radiologically, and the resection specimen is must to call it Crohn's, because in Crohn's you are having skip lesions. The pattern of distribution is very important for the disease. So the skip lesions are only seen on resection specimen. So these are some drawbacks of small endoscopic biopsies. And a few words about Crohn's. The pathogenesis is poorly understood as it is idiopathic. It is one of the spectrum of idiopathic inflammatory bowel disease. And in Crohn's, grossly, we have linear and serpiginous ulcers, which are intermixed with the non-ulcerated mucosa, giving it a cobblestone appearance. And in Crohn's also, as I've told you, the granulomas are also there, but how they are different from tuberculosis granulomas are, they are non-caseating ones. So, and in Crohn's, the very important, which I routinely do, I always call and ask my clinician friend that whether the rectal involvement is there or not. Because to label it as Crohn's disease, to give it on the resection specimen, I have to be very sure that Crohn's start from terminal ileum, and then the colorectal involvement is very, very rare. Rectum is usually not involved, whereas the ulcerative colitis is the one which is definitely involving your rectum. And no bacteria is identified in Crohn's disease. These are some different differential features from abdominal tuberculosis. So, talking about the gross images of Crohn's disease, the figure number 1 shows the presence of characteristic cobblestone appearance. What is this cobblestone appearance? As you can see, marked by the arrow, there are presence of these mucosal outpouching. So they are linear and serpiginous ulcers, and in between these linear and serpiginous ulcer, there are presence of not involved, the unremarkable mucosa, giving it the appearance of cobblestone. Whereas in case of tuberculosis, you have seen there are presence of transverse ulcers, there are strictures, and then there is fibrosis. The second image is showing you there is presence of this stricture, and you can see the mucosa is completely inflamed in comparison to tuberculosis, where you are just getting fibrosis and transverse ulcers and hypertrophy and involvement of the lymph nodes. Involvement of the lymph nodes will not be here in case of Crohn's disease. So, just discussing in brief what are the important points for microscopy of Crohn's disease. We look for two things. First, the features of chronicity, and second, the features of activity. So as the name indicates, the features of chronicity are when there is crypt architectural distortion. So even on small biopsies, we have to look for crypt morphology. If the crypt architectural distortion is there, then you cannot label it as abdominal tuberculosis, because crypts are more or less normal in abdominal tuberculosis cases. And also, another feature of chronicity is expansion of lamina propria with basal lymphoplasma cytosis. I again emphasize here, it is basal lymphoplasma cytosis, not just lymphocyte. Presence of plasma cell is mandatory. Now, what are the features of activity? Activity means presence of neutrophils. So neutrophils, once the neutrophils are present within the wall of the crypts, it is called cryptitis. Once they come within the lumen of the crypts, it becomes crypt abscess. And later on, it will break down the crypts, leading to crypt distortion. That is a feature of chronicity. I will be discussing about it in my coming slides. So the granulomas are characteristic, but only present in 50% of cases in Crohn's disease. They are often well formed. How they are different from tubercular granulomas? They are usually well formed, but they are sarcoid like. By sarcoid like, what I mean, they are naked granulomas. The fibroblastic rim is absent in Crohn's disease granulomas. Second, the caseous necrosis is not there. Usually, you just see the presence of giant multinucleated giant cells, and that too not Langerhans giant cells. So the important thing here are, so the small biopsies are limited in determining the depth and distribution of the inflammation in case of Crohn's disease. Therefore, diagnosis is often reliant on clinical correlation or examination of the resection specimen. Because in Crohn's disease, you have to look for the skip lesions. And the differentiating features from tuberculosis is the presence of granulomas. The presentation grossly is also different, and microscopically also the granulomas differ in both the conditions. So how the granulomas of Crohn's disease are different from tubercular granulomas. So again, this is from the HE picture is from the terminal ileum. Now you can see marked by the arrow. In the lamina propria, there is this image. These are non-caseating epithelioid cell granuloma within the lamina propria marked by the arrow. Here you can see there is no caseous necrosis. There are no giant cells, just the collection of epithelioid cells. So, and that too, they are also seen only in 40 to 60% of the cases. But the absence of granuloma does not exclude your Crohn's disease. So in that case, if only we are seeing granuloma, no caseous necrosis is there, then we have to keep tuberculosis as our first differential, and second differential would be Crohn's. Again, in figure number 4, you can see there is presence of these granuloma. Mainly, you can see the giant cells, and it is present within the muscularis propria. The figure 3, it is showing within the lamina propria, and it is showing within the muscularis propria, indicating because Crohn's usually have transmural inflammation starting from lamina propria and going till serosa. In figure number 5, you can see non-caseating epithelioid cell granuloma, the hyper image in muscle layer, and all you can see are these multinucleated giant cells only. And how these giant cells are different from Langerhans giant cells? Because as I've told you, the nuclei position is very important. Now, the important feature I'm talking about is activity. You have to look for the crypt morphology. Many a times we write in our report, there is presence of crypt abscess, there are presence of crypt architectural distortion. What do we see when we call that? So in figure number 6, you can see there are presence of these multiple crypts. As I have marked by the arrow, there are presence of these neutrophils within the crypt lumen. So numerous neutrophils within the crypt lumen is a diagnostic hallmark. That is, we call it crypt abscess. And as you can see, these neutrophils, they are distorting the crypts. The crypts are of variable size. And this feature is crypt architectural distortion, and this is the feature of chronicity. Now, in figure number 7, you can see again the hyperview of the crypts. As I've marked with the arrow, there are presence of these neutrophils within the crypt epithelium, and that is inflammation of the crypts. When you see the neutrophils within the crypt epithelium, that is nothing, just the inflammation of the crypts, and that is cryptitis. So these are the features of activity. This you see in Crohn's, this you will not see in tuberculosis. Again, as I've told you, the resection specimen is must to label it as Crohn's specimen. This is a colectomy specimen from a patient of Crohn's disease. Now, you can see marked by the arrow right in the center, the mucosa is normal, whereas it is surrounded by on both the sides by ulceration. So on right hand side, on left hand side, the mucosa is denuded and it is replaced by acute granulation tissue. So that indicates that it's a skip lesion because the inflammatory process is not continuous. Second thing, you can see marked by the star, there are presence of these lymphoid aggregates which are there. So the diagnostic features here are the deep ulcers and fissures can be seen in later stages. The transmural inflammation is there and the non-caseating granulomas are there, which are very important in differentiating it from tubercular granulomas. Next slide, please. Many a times we do report chronic non-specific inflammatory pathology. Now, what do we understand by it? Why do we report it like this? When there are no diagnostic features of concerned disease or disorder identified within the biopsy submitted, the small biopsies I'm talking about here. And second, in that scenario, what we do, we usually call up our clinical friend and we correlate clinically that what are the endoscopic findings. And we usually ask for the repeat biopsy from more representative area. Now, and especially on the clinical grounds, if the clinical suspicion is there, then we ask for the repeat biopsy. Then most important, mild chronic inflammatory infiltrate should be there. That is predominantly lymphocytes. It should be there, but there should be absence of plasma cells. So these are the 3 points when we call it chronic non-specific inflammatory pathology, when there are no diagnostic features. And second, we ask for repeat biopsies, morely on the clinical grounds. And when there is just presence of chronic inflammation, no granuloma, no necrosis, no crypt morphology distortion, nothing. And there are no plasma cells, just lymphocytes. Thank you, sir.
Thank you, Dr. Vandana. There are many points you have covered. I think the most important thing we have by your presentation is how to differentiate abdominal tuberculosis from the Crohn's. So I wanted just to ask you, because you talked about biopsy specimen or resected specimen, and sometimes from the lymph node people do talk about FNAC also. So what is your comment about FNA? If somebody is doing FNA, is it possible to diagnose abdominal tuberculosis from the lymph node?
Sir, usually the FNAC is a inconclusive investigation. The biopsy is definitely diagnostic because in biopsy you get to see more tissues, and most of the times in FNAC the cellularity is not there. So there are some drawbacks of FNACs, and definitely biopsy is having an upper hand over FNAC, sir. Because in biopsy you are seeing much tissues, whereas in FNAC most of the time it is acellular or it is hemorrhagic, or they do not hit the lesion because it is heterogeneous. So that is how, sir, the biopsy is diagnostic.
One message is clear that we should have either a biopsy, even if we are doing a needle biopsy. And,
yes, sir.
And the second is important message is that we need to have a good chunk of tissue. So just to re-emphasize for the people who are listening, that you said that the hallmark is epithelioid granuloma, which can be differentiated from Crohn's. If it is in Crohn's, it would be transmural, but it is usually not transmural in a case of tuberculosis. And giant cells, Langhans giant cells is usually in tuberculosis, but these typical cells are missing in a Crohn's. And
it's a caseous necrosis.
Yeah. So caseation, you talked about what percent of the people in abdominal tuberculosis we get caseation. I hope it is less common in abdominal tuberculosis. So what percent and then is it very difficult to diagnose tuberculosis in the absence of caseating necrosis?
Sir, I've told you, we do receive specimens, but we really work in a holistic manner. We have to ask about the B symptoms, the fever, the evening rise of temperature, and the weight loss, anorexia, all that. And then we do get these in small biopsies also. If there is presence of granuloma, most of the times we do get presence of granulomas, sir, and that too caseating granulomas. So we do differentiate it from Crohn's. And malignancy is entirely different thing, sir.
So I would like other senior people to give their comments,
Yeah,
please.
Chetna,
Yes,
again, just an additional point that what Dr. TD was saying that on FNAC, can you
Yes, sir.
see caseation necrosis? Can you see Langerhans giant cells? Because
Yes,
many a
sir.
time,
Sir,
yeah,
in FNAC, if the FNAC has been taken from the representative area, we do see caseous necrosis, sir, but the chances of getting Langerhans giant cells are not much.
but
But
sometimes it is possible for you to say on
sometimes,
FNAC that it is tuberculosis.
yes, sir, definitely. And sir, one more important thing I would like to emphasize here. Usually, in case of tuberculosis, when the FNAC is done from the cervical lymph node, then it is very much representative. We give it as a tuberculosis, but in mesenteric lymph node involvement, the upper hand is of biopsy, sir.
Yeah, because in the neck, you don't
Yes,
expect
sir.
Crohn's disease to be there.
Yes, sir. Yes, sir. And it is easily done.
Okay.